Good evening. This presentation will start and end with Smile Train, and in between that you'll be seeing a lot of pictures. Cleft care is essentially this one line by Millard, always searching, never quite attaining perfection. So in I have been involved with Cleft care right from MCH days, but in North Bengal it was after partnership with Smile Train, and then initially we used to do camps in many places, and then we used to partner with the BSF, SSB, many NGOs, and there in 2017 there was an MOU that Smile Train signed with RBSK, and from all these regions patients were sent to our center for treatment. These are my numbers so far, the number of surgeries, the various surgeries that was done, and then the speech therapy and the nutrition program. So what do we essentially do? Like all other centers, we start the lip at 6 months, the palate at 9 months, and if required, preschool secondary revisions, and alveolar bone grafting depending on when the canine root comes out, and mixed dentition and rhinoplasty at 12 to 14 years. All the other treatments excepting the orthognathic surgery is fully sponsored by Smile Train and is free for the patients. The child which you saw having an ABG here, that is the same child with a lip at 6 months and a palate at 2 years. Additional services, we give nutrition services and speech services. Now, speech therapy has been available at our center right from 2010, but then it got sponsored by Smile Train from 2021. So now the patients are able to access it free. We also provide nutrition services. Now, these children come from such poor backgrounds and so malnourished that we are not only now giving counseling sessions to them, we are able to give them monthly rations of rice, dal, eggs, etc. We monitor their growth and this essentially make them fit for surgery. So now 206 children have been given nutrition so far, 180 operated. The same puny child which you see after building up the child now has had a lip repair and has come for a palate. Orthodontia is another thing which again, ABG we have done for the past 15 years, but privately done orthodontia, but now that is also getting sponsored from Smile Train. So our protocol is this, but then this is a daunting task because most of these children are malnourished, have some LRTI, and they are not adequately immunized, and we have other congenital anomalies which also have to be taken care of. So we bring them to this level is very, very difficult, and within 6 months, they usually don't even reach 6 months and they die before that. When they are ultimately admitted, then before surgery, maintaining dehydration and hypoglycemia, preventing all those things is key. So these are the standard orders. My children are kept till oral only 2 hours before surgery and for 1 hour after that. After that, they are fed normal milk, only liquid diet for 2 days, and they eat the normal diet, whatever they were eating before, after 2 days, be it a lip or a palate. So this is the standard post-op, and in long-term post-op, we ask them to have a good oral hygiene, we teach them exercises, speech therapy, and for the lip, it is the scar care. Suppose they don't talk to us, then we give them balloons, whistles, and to sort of assess what is the palate and how it is functioning in these children. Now, before surgery per se, I want to emphasize on the infiltration anesthesia we use. Why? Because if this anesthesia is adequate, then you require very little other anesthetic agents and relaxants. So we use the maximum dose of lidocaine with adrenaline is 7 milligram per kilogram. Suppose you take that standard 2 ml vial. In a 10 kilo child, the maximum you can give is only 3 ml, and that is not adequate infiltration. But if you dilute it to 0.5, then you can give about 14 ml. So how do we do this? How do we give this? We take in an insulin syringe about 13 units of adrenaline and add it to 30 ml of 2% xylocaine. So that gives a dilution ratio of 1 in 1 lakh adrenaline. Then what we do, we take 3 ml which is for a 10 kilo child and dilute it nearly 4 times, and that 12 ml is adequate for infiltration. When we infiltrate, it has to be slow, it has to be, you have to repeatedly aspirate, you have to feel a resistance, and this is the dose. 0.5 and 1 in 4 lakh is enough for adequate anesthesia, good hemostasis, and a pain-free surgery. We have to be certain that we don't cause a lot of difference in the pulse and the BP of the child. Why am I so dogmatic about this? Because in these 5,000 children that I've operated, I've had one death. And that death is even before I could lay a knife. And when we gave the anesthetic itself, the cardiac rhythm galloped, the child went into arrest, and all our resuscitations failed. Therefore, and a detailed inquiry by Smile Train told us that maybe it was an inadvertent intravascular injection along in a child who has a cardiac anomaly. So routinely we do echo in our pre-ops. Coming to the lip repair per se, I almost always do a Millard's rotation advancement. It is a wonderful repair, but then sometimes when the rotation is very short, then I do a Mohole variant where we take the back cut into the columella. Fissure, suppose I have a lot of tissue to discard and the philtrum goes straight into the nostril. We'll start from the previous first cases and I will show you long-term follow-ups to find out how every case has evolutionized. Okay, the first one, when I started up, I used to do a lip and a palate without doing any nose work. So after this child grew, she had an orthodontia ABG and she's happy with her nose, nothing further was required. First what we did was only closed lifting of the lower alar cartilages, and I used to hitch it to with a bolster to the skin on the opposite side, but that used to leave an unsightly scar on the skin and we stopped that. Even back in 2007, when I found the philtral column going straight into the nostril, a fissure is a more aesthetic repair. Slowly we realized some things. The problem of the peaking of the scar of Millard, it slowly settles with age. The nose characteristics keep changing and patients are mostly much more happier with their appearance than we are. This lady, this small child is now this lady who's happily married, and when I told her that please come for a rhinoplasty, she was amused by my suggestion. Then in some cases where we think that the child is presenting late or if the parents are not very keen on following up, we do the palate first because they will definitely come back for the lip repair. Once a child done like this, where she grew up, she was obviously not very happy with the nose, and then I finished it off with a rhinoplasty in her. Incomplete cleft lips. These are more challenging overall because the defect is very minimal. The parents' expectations are maximal, and that is the case where we developed hypertrophic scars, Bermillon mismatch, we miss a nasal deformity, and we can even miss an alveolar notch. That here does not appear, but as she grows older, there is a malaligned tooth. Slowly, our nasal repair became more elaborate. The septum was centered, the excess septum graft was used for the columella strut, and we used to dissect the ala and do transfixion sutures, and this is one of our poster girls. You will see her in the Smile Train India website and in many other social media platforms. So slowly I started emphasizing on using the L and the M flaps for sort of giving an additional support to the nostril flow, and as we started doing that, we found that the need for the ABG later on started reducing. So by COVID, we did not use any suture removals. We stopped suture removal and started using absorbable 6-0 Vicryl for the skin, and that immediately led to a much more better scar of the lip. So this is only the certain differences in the lip repair which I am showing you in this video. I use a L flap which is based on the alveolus. This is a speeded up video, so you will see it rapidly. And then the septum is centered. The curved portion of the septum on the ovarine groove is excised, and that is used for columella struts. You can see the septal flap developing on the other side, and with the lateral maxilla you close this nostril flow well. Then the L flap is taken across the defect and sort of closes that defect, maybe some similar to a GPP repair. The L and the M flaps are then sutured so that you form an additional reinforcement of the nostril flow. The advancement flap, I don't pull it to the medial, but then it is sutured with the L flap itself. So there is tension of the advancement flap goes down very remarkably, and the lip is much more natural and in repose at the end of this surgery. So here the L and the advancement is getting sutured. So that is how it finally ends, and you have after doing the rest of the repair. So in summary, unilateral cleft lip, repair the nasal floor well and use the L and M flaps without discarding them. Septal dissection, close rhinoplasty, and use absorbable sutures, and they will give you much better result. Now we come to bilateral cleft lip. Perspectives are very simple. Whenever it is incomplete, whenever it is the premaxilla is in place, you can do a very gratifying repair. And depending upon the number, the formation of the white roll, from where it comes, you have many types of bilateral cleft lip repair. I usually do a Millard Fort flap. I don't use the forks, and where the scar forms the white roll, and it is a pretty good white roll, no real problem in that. Now, initially again when I started off, I never used to touch the nose. Now what do I do in a bilateral cleft lip now? Only dissect the alar cartilages and hitch them together. No touching the septum, because when you dissect the septum in a small child, there is a high chance of nasal obstruction, and that can be very scary and even fatal. And therefore, unless you are routinely putting in the nasal splints, you don't touch the nose, nasal septum. So close the lane. The most important thing in a bilateral cleft lip is close the muscle adequately above the maxilla, premaxilla, so that it is brought down slowly without any compression. Even in this child, you can see the premaxilla coming down, and an ABG could be done without orthodontia. This case where you find the premaxilla completely excluded from the maxillary arch, even here, do a lip repair, wait, and you will see the premaxilla coming down. But what are the two most important problems in a bilateral cleft lip? You can have a deficient sulcus and you have a vissel deformity because there is a reduced central vermilion. In those cases, you may have to do an LNR, an orthodontia, an Abbey flap, so that you can bring in the central vermilion and later on do the ABG, and there, this is the final result. Another case of a high riding premaxilla repaired with a palate first technique. Slowly then we have done an Abbey in her also, and the orthodontia itself has been used to sort of narrow the anterior fistula that has occurred. This is a syndromic child, wide cleft with an overlapping twisted premaxilla. In this case, narrow this wide defect with a lip addition, you will get some lip restraint, and later on you will be able to do a bilateral repair. And this child, even the palate was repaired only with buccal mucosal flaps because of the excessive width, and this unique challenge was even published in the IJS. Now you have these type of children where in an adult, whatever you do, you cannot get an adequate lip seal, and that is when we think that maybe we should do a maxillary setback. After talking with Dr. Karun Agarwal, he said, no, go ahead, do it, because I have cases where the maxilla is not resorbed. I have seen premaxillary resorption, so I am very worried. But then we started doing it recently, and you can immediately see there is a striking improvement in the aesthetics after you've done a setback in these children. So BCLP, what is the summary? It is slightly easier to read. Attain symmetry if the premaxilla is good. Nasoalveolar molding, if it is available, can do a huge benefit in these cases, but we don't have it regularly. We are just starting, and maybe in later cases we could do a setback. Now we come to palate repair. I do the Bardak 2 flap mostly, and there are certain important steps, but you will have to free the artery completely. I do a Z on the nasal layer and thereby push it back. The muscle also is pushed back, and try to minimize the lateral alveolar gaps. No white flaps. The two mucoperiosteal flaps that you elevate should be pink and bleed well. If not, then there is a problem, and I use only absorbable sutures. I will be telling you that. So this is what is a palate repair. After we identify the vessel well, then you put in the Michel's trimmer, isolate the artery completely, and so that when you isolate it completely, then you can see the flap pulsating on the vessel. So this is done bilaterally. After that, a Z on the nasal layer, I use 4-0 chromic catgut with continuous suturing, and sometimes I lock it in between. So that Z sort of pushes the muscle behind. And after that, you see the palatoglossus and the palatopharyngeus and the levator down, and then you can just bring them closer by stitches in the center. When you do a transverse shortening, you get again a lengthening in the longitudinal direction. So that is how the muscle forms, and these are the alveolar gaps which are sutured. So this is what is done. Now, in way back in 2007, I did this lip repair, this minimum expense.
আমার নাম প্রজ্ঞা রায়, আমি বীরপাড়া থেকে আলিপুরদুয়ার বীরপাড়া থেকে এসেছি। হার যতীন্দ্রনাথ সেনগুপ্ত, দূরে দূরে গ্রাম 10-12 খানি, মাঝে একখানি হার, সন্ধ্যায় এসে থা জ্বলে না প্রদীপ, প্রভাতে পড়ে না ঝাড়, বেচা কেনা সেরে বিকাল বেলায় যে জাহাজ সবে ঘরে ফিরে যায়, বকের পাখায় আলোক লুকায় ছাড়িয়া পূবের মাঠ, দূরে দূরে গ্রামে জেলে ওঠে দিন, আধারেতে থাকে আর নিশা নামে দূরে শ্রেণীহারা একা ক্লান্ত কাকের পাখে।
So her Bengali is even too much for me. And the other primary repair that I do is a von Langenbach palatoplasty in some specific group 2 clefts. So by 2014, this is the left UCLP patient. Our palate became sort of streamlined. A lip always will require some tweaking later on. And we heard a lot of shloka today.
আমার বাবার নাম বিশাল বর্মন, 61, 62, 63, ধর্মক্ষেত্রে কুরুক্ষেত্রে সমবেদা জয়স্তব মম কায়ম পাণ্ডব কিঙ্করবত সঞ্জয় যদা যদা হি ধর্মস্য গ্লানি ভবতি ভারত অবুর্যথন্নম ধর্মস্য তদত্তনয়ম সিদ্ধমহম পরিত্রায়ণ সাধনম বিনক্কয়স দুষ্কৃতম ধর্মস্য স্থাপনায় সম্ভব ভবানী যুগে যুগে। ভগবান শ্রীকৃষ্ণ অতি যুগে যুগে ধর্মদের।
So that is what he tells me. And then this is another group 2 child who came back 6 years later. She has lost her anterior teeth now, and so she speaks like this.
Sunshine is good. White on a blue hill. When the wind stops, you all stand still. When the wind blows, you walk away slow. White sheep, where do you go?
So the dreaded complication of a palate is fistula, and when I looked at my numbers, I was quite heartening to see that my fistula rate is only about 1.25. And why do these fistulas occur? We should have some knowledge so that we can prevent it. The first child, the fistula came from outside and I repaired it. But the second person, he's an adult, but the nostril flow is not repaired. So I always feel that when the nostril flow is not repaired, there is a more chance of anterior fistulas, very difficult to repair them again. I don't use these vicryl sutures, long-lasting vicryl sutures now, because after I switched over to absorbable, then the results are much, much better. Now in this child, you see this right flap is white. That means there is some tension on the pedicle. So it will always break down, and it is best avoided, and then we can avoid a fistula. Now going back to Smile Train. So you have these challenges in Smile Train, doing Smile Train. It is a high-risk program with a very low budget. But then I would want all our junior colleagues to still do cleft work. Why? Because you can do a comprehensive care right from infancy to adulthood without worrying whether the patient can pay for it. And that is something great, because you have a chance to make such an amount of difference in these people's lives. When these people get on shows projected on social media, that gives you another big high. And because of Smile Train only, I was recognized by the government, and I was able to get many international and national accolades. I also got the American Society of Plastic Surgery Fellowship because of Smile Train. Not only all these things, when a small child that you have done comes back in a later age and she's able to do this.
ও হয় মন সেই ছবিখান নষ্ট করে কুঞ্জনা কুঞ্জনা, সেই ছবিখান নষ্ট করে কুঞ্জনা কুঞ্জনা, তোমার ঘরে বসত করে কয়জনা মন জানো না, তোমার ঘরে বসত করে কয়জনা।
So again an appeal to all the young trainees, please do aesthetic work. I know most of you registered for aesthetic work, but then be a smile maker also. It is definitely a very, very heartening and a rewarding life. This is my core team. Thank you again. Thank you to Dr. Bhattacharya for inviting me to come and present my work here, and thank you for all the organizers for such a lovely conference. Thank you so much.